Okay, so the idea now is to talk about dizziness and vertigo from a American Year Professional Edition. It will be an overview. It won't go deep to each of the pathologies. We are not going to talk about suprasemicircular canal or autosclerosis or, I don't know, Meniere disease in very deeply or any pathology in the inner ear that is significant. I will mention the important pathology for vertigo. Meniere is one of them, and also vestibular neuritis and labyrinthitis, but not only this. And we are not only going to talk about vertigo, which is defined as the feeling of motion of yourself or the surrounding without any real motion. This is the definition of vertigo, as you can see here. But we're also going to talk about dizziness, which can be described by the patient in very different ways. Described here: lightheadedness, faintness, vagus, swimming, spinning sensation. It's not really clear the definition between the differentiation between vertigo and dizziness. So sometimes it's better to take them just as a one description and not too much to get into the details. Uh, okay. So the pathophysiology can be a disruption in the vestibular apparatus of the inner ear, a disruption in the eighth cranial nerve, disruption of the vestibular nuclei. This is from the inner ear, but we will see that there are a vertigo that can be caused by different organs, not just the inner ear, which we can see here. Here you can see the ear. Here is the ear canal. Here is the tympanic membrane. Those are the ossicular chain, which we have the malleolus, incus, and stapes. Here are the vestibular. This is the auditory nerve, or let's call him the eighth cranial nerve, which is the vestibulocochlear nerve, which, as the name suggests, split into the vestibular part and the cochlear part. Vestibular part, here we have the semicircular canals. Here we have pathologies like BPPV, benign paroxysmal positional vertigo, which is maybe the most common cause of inner ear vertigo. Here, sometimes the otoliths from the sacral or utricos get out of the otolith and get out of the utricle sacral, and this otolith get into the semicircular canal. The most common one for VVV is the posterior, and when it gets inside, it can cause vibration and motion that are not real, and the patient just feels that there is motion. This is the idea mechanism of VVV in the semicircular canal in the vestibular part. Here is the cochlear part, and this is the Eustachian tube here. This is the middle ear space here, tympanic cavity also. Here we have the windows, the round window, the oval window. The windows sometimes can rupture and cause perilymph fistula, which can also cause vertigo. So we can see that in this very small space, we can have many different pathologies. We can also talk about Meniere, where there is overflow of endolymph hydrops. We can talk about autosclerosis. We can talk about ossicular chain disruption. We can talk about a tympanic membrane perforation. We can talk about suprasemicircular canal dehiscence here, where there is a dehiscence and the temporal bone is a little bit not complete. We can talk about very different etiologies for inner ear pathologies that can cause dizziness, vertigo, tinnitus, and hearing loss. Depends on the pathology. This is the hearing loss type, sensory neural or conductive hearing loss. So I tried to describe it to you a little bit. We have three semicircular canals, as you can see here. One, two, three, anterior, posterior, and horizontal. Yes, I'm not mistaken. Okay, here is also an inner ear model. I won't get into this too much, but this is a model of the inner ear. As you can see right over here, there is the tympanic membrane. It's moving very fast, I must say. Tympanic membrane, there are the ossicular chain. Here we can see the incus with the oval window. Here is the vestibular with the three semicircular canals. Here we can see the cochlea. This is the nerve, the vestibulocochlear nerve, the eighth cranial nerve, and we can see here the tensor tympani. There is also for the stapes and a muscle. I'm not sure that this is not just this is the Eustachian tube, just the Eustachian tube, which tensor tympani, yes. Okay, okay. So the most common etiologies of different dizziness and vertigo, peripheral vestibular system, are those four. Benign polarization position of vertigo is this BVVV, which is when the otolith goes to the semicircular canals, as I said before, and can cause their motion of the endolymph and then vertigo. Usually the vertigo in BPPV is positional dependent. When the patient moves his head, there is a strike of vertigo, sometimes with nausea and vomiting. It's very, very limiting. And after 2 minutes, 3 minutes, the attack subsides. And then when he also moves his head again, it can come back. It can last for few weeks without treatment. With treatment with Appli maneuver, it can be treated and usually should last less days. The way to diagnose it is usually the deep soul pike if the PPPV is in posterior semicircular canal. There is role for different semicircular canals, but the 85% of PPPV is in the posterior semicircular canal. Meniere disease, endolymph hydrops, we have attacks of vertigo, tinnitus, and hearing loss. Usually the hearing loss is in the low frequency. In Meniere disease, there are some treatments like salt diet, like diuretics, like hydrochlorothiazide, like tympanic membrane or inner ear injections of gentamicin, which can destroy the inner ear, endolymph sac, drainage, and sometimes cutting the vestibular cochlear nerve. Vestibular neuritis and labyrinthitis. Vestibular neuritis usually, uh, let's start with what is it. Vestibular neuritis is inflammation of the vestibular nerve. It usually happens as a response or as a cause of a virus, lasts for some days and days then subsides. It can be treated for symptomatically with antihistamines in the first generation, like beta histine or uh, other types of antihistamines. It can also be treated sometimes with diazepam, namely benzodiazepines, and usually you can see nystagmus. There is another thing which is called labyrinthitis. You can consider it viral labyrinthitis, which is inflammation of the labyrinth, and usually also the cochlea is involved in the vestibular nerve. So in when we are talking about vestibular neuritis, usually there is no tinnitus and no hearing loss, only the vertigo, because only the nerve is involved. But in labyrinthitis, where the labyrinth and the vestibular nerve are involved and the cochlea are involved, so usually they have tinnitus, hearing loss, and vertigo. Now, labyrinthitis can be viral. Sometimes it is also called as vestibular neuritis, but labyrinthitis should include the cochlea and the labyrinth, which is important because it also causes tinnitus and hearing loss, which should be usually absent in vestibular neuritis. In bacterial labyrinthitis, the treatment is different. It can come from otitis media, which spreads to the labyrinth. It can be much harder and much severe disease with dramatic hearing loss, and the treatment can include sometimes antibiotics, for example. It's different one. It's called purulent labyrinthitis. So those Four are the most common cause of vertigo from peripheral vestibular system. When we're talking about peripheral, we're talking about not CNS related, not a stroke, not multiple sclerosis, not hemorrhage in the, I don't know, brainstem, not these ones. These ones are CNS related. We're talking about peripheral, usually in the inner ear. Most common of dizziness is drug effects. For example, I don't know, antihistamines or other drugs that can cause dizziness, and multifactorial idiopathic. You can see here different things that can cause dizziness and vertigo, like hypoxemia, anemia, hypoglycemia, syncope, thyroid disease, hypo or hyper, panic disorder, hyperventilation syndrome, anxiety, depression. There is even a list here of causes of dizziness and vertigo from peripheral vestibular system. We have the PPVV here, which can be identified using the deep solfaing maneuver and treated with the Apley maneuver. Each episode is brief of vertigo when after the head is moved, the otolith moves and causes vertigo. Meniere disease causes recurrent episode of tinnitus, vertigo, hearing loss usually in the lower frequencies. Vestibular neuritis, viral cause usually can cause nystagmus. For some day, very intense vertigo without hearing loss, without tinnitus usually. Labyrinthitis can cause hearing loss and tinnitus also in adding to the vestibular neuritis. Sometimes it's hard to differentiate between peripheral and central vertigo, like from basilar stroke, for example. There are tests like the Hintz tests with skew, with head tilt, with nystagmus. For example, nystagmus from peripheral disease is usually fatigue, but by fixation of what you see, you fix on something, and nystagmus should subside if it's peripheral. Central does not fatigue. So, and usually central shouldn't have tinnitus, vertigo, except maybe for things like schwannoma, acoustic schwannoma, but let's consider it is as a peripheral one. But if we're not sure if it's central from basilar stroke, for example, or for intracranial hemorrhage in the, I don't know, brainstem, so we can also do imaging like CT or MRI angiography by the reading hands. Otitis media, which can be complicated by labyrinthitis, like bacterial labyrinthitis, can cause what you expect from otitis media with the panic membrane bulging, erythema, pain, some usually with congestion for upper respiratory tract disease, trauma. Trauma can also cause it, post-concussion syndrome, perilymphatic fistula. This is it. Tympanic membrane perforation, all of this can cause vertigo. Vestibular schwannoma, acoustic neurinoma can cause tinnitus, tinnitus, hearing loss, unilateral, usually unilateral hearing loss, sensory neural hearing loss with tinnitus is and discrimination deficiency is quite common. Ototoxic drugs usually cause bilateral, like neomycin of the aminoglycoside. Herpes zoster can cause Ramsay-Hunt syndrome, which can be seen as vesicles above erythema. This is the rash of herpes. It can affect the vestibular system if it's near the ear, on the ear, and can cause Ramsay-Hunt syndrome. Motion sickness is a motion sickness and central vestibular system like brainstem hemorrhage, cerebral hemorrhage, migraine, multiple sclerosis, vertebral artery dissection, vertebral insufficiency. You can see global disruption of CNS function like anemia, CNS active drugs, and hypoglycemia and hypotension, for example, orthostatic hypotension. Hypoglycemia, especially for patient who takes drugs that can cause hypoglycemia, like diabetic patients, like insulin, like sulfa, hypoxemia, for example, from, I don't know, COPD or something. Other causes is PPPD, persistent perceptual postural dizziness. Usually after a disease, for example, PPPV, the patient may have residual dizziness and vertigo, so you can call it quite persistent perceptual postural dizziness. Pregnancy, psychiatric, like panic attack, hyperventilation can cause it. syphilis, thyroid disorders, hyper or hyper. Syphilis usually neurosyphilis that can cause damage to the inner ear in the second or third stage of syphilis. Uncompensated peripheral vestibular weakness like can happen in vestibular neuritis. This is a list of the causes of vertigo and dizziness. You can see how long it is. There are central, peripheral, and other causes of vertigo. Evaluation, you can see the evaluation right here. Red flags are head and neck pain, maybe dissection of the vertebral artery, ataxia, which can tell you that it's usually more common in the CNS disease, loss of consciousness, which should not happen in peripheral disease, focal neurological deficiency, which direct you to a CNS disease like hemorrhage or stroke, severe continuous symptoms for more than 1 hour. Okay, now you can see here what is more characteristic of peripheral and central vertigo. Peripheral usually with ear symptoms like tinnitus, phoniness, hearing loss, vertigo, non-generalized dizziness, symptoms paroxysmal usually, severe and episodic like BBVV. Continued dizziness for months is not usually from peripheral, it's for central. Loss of consciousness is usually not associated. Central, there are no usually ear symptoms. Balance may be disrupted. Nystagmus is usually not inhibited by visual fixation, which is in comparison to the peripheral nystagmus, which is inhibited by visual fixation. Now, testing depends on the etiology. As you saw right over here in this column, there are the tests like deep hole pike for BPV, and for each one there is the test, and the treatment is accordingly. Treatment for vestibular neuritis, labyrinthitis, Meniere, we can take a vestibular suppression drugs like antihistamine first generation like this, or benzodiazepine like diazepam. For nausea, you can take metoclopramide, things like this. This usually can be taken for short term, for some days, like for example in vestibular neuritis, when we think that the vertigo will last only for some days and not long, so you can give it. Apply maneuver for BPPV for repositioning of the otolith, and diuretic and low salt diet for Meniere. We have more treatment, but this is for the beginning. Okay, and geriatrics, usually because their system is much weaker, they are more prone for dizziness and vertigo. Note that they can fall and have fractures, so they need to be careful. And that's it. This was about vertigo and dizziness overview from Make Manual Professional Edition. Thank you very much. If there are any mistakes or corrections, please tell me, and that's it.